Ooh, okay. Well, welcome everyone to the Physical Therapy Month edition of the Lunch and Learn. We're excited to have Rick Katz here with us. And just one note, Rick did ask us to update the name of this Lunch and Learn to look at where we came from and where we're going, which we neglected to do. So just letting you guys know what we're kind of getting into. But does everyone here know Rick Katz? Just as a brief introduction for him, he is our Vice President of Business Development, and he kind of works to make sure that we're partnering with people in California as we kind of move through the state. I'm sure he can go into a better introduction than that, but we are excited to have him on today to give us a little something to think about. Rick?
Thank you, Nina. Hi, everybody. I know this is kind of like a filled hour for you with your other meetings that you're coming from, so I appreciate you joining. I'm going to get into sharing the screen here so that we can get into, oh, it's in the last slide. Let's go to the first slide. Okay, that's the whole presentation, so we're done. Anyway, so I did change the name of this one. I was going to talk about the value of physical therapy, and there's another whole presentation on that. But considering this is Physical Therapy Month, and it is the kind of the end of the APTA centennial year. So the American Physical Therapy Association has been in existence for 100 years. I thought it might be kind of cool just to look at the history of PT, because I know, you have all been through PT school. You probably had your intro to PT, those of you who've been in PT school, intro to PT in the profession. But I thought it'd be kind of cool just to see how we've evolved as a PT community and profession over the last 100 years. And the fact that we are so young, it's just kind of amazing how far we've come, thinking about the history of medicine in general. So this is kind of just a quick retrospective. And so just so you know, this is all not from personal experience. So if I go back 100 years, it's not like I lived this stuff, but some of it I have. So for well, not half of it, but close to half of it. So we are celebrating 100 years. And this is actually a depiction of the Rose Parade float that we are going to have on January 1, we being the California PT Association. So I'll be up there waving my hand with my wave. But it's a float design that kind of shows the progression of movement, and we are going to have a lot of people riding on the float and walking alongside the float that are recipients of physical therapy and represent the diversity in the profession of physical therapy and where we've come from. So this is something that is put on by the California Physical Therapy Association, and the APTA is also going to be represented on there with having our APTA president with me up there on the float. So look for us on January 1, and you can say, I know that person. So as PT used to be, is when the profession evolved, it was really interesting to see how when I was starting to treat patients back in the 1970s, so a long time, how we were so dependent on not as much what we did with our hands, but just what we applied to patients, how we utilize physical agents, and how then the manual therapy and Therex and movement actually became kind of a byproduct of everything we did. We didn't always think about movement as being the primary goal of what we were trying to do, as we do now. Now we always think about how do we get that person back to doing something? What is the activity? What is the function? What is the work requirement? Those types of things. Back then it was, okay, let's take care of the pain. Let's make them less sore. Let's build up their strength. And we didn't always think about what those things meant for the patient in terms of the outcome. So that's kind of how the profession started out. And it goes way back to, to the fact that they use physical agents with hydrotherapy, massage, heat, cold when available. But back in the old days, cold was kind of a novel thing. So it was mostly heat. And that's kind of, therapeutic baths and those types of things were really the foundation of what we did. And we called ourselves back in the early days physiotherapists. In fact, if you do go to even Canada or England, Physiotherapist is the terminology that is used. And in the California PT Practice Act, we are allowed to call ourselves physiotherapists. Those terms, physical therapists and physiotherapists, are synonymous terms in our state law. You probably didn't even know that. And back then, massage was kind of, very much part of what PT was, and physical education kind of evolved from that group of people. So the birth of PT really, and I'll show you kind of a timeline here in a minute to visualize a little bit better, but it really came out of World War I, when there was a need to take care of the people who were injured in war. And so it was born out of really the nursing profession, and an offshoot of the nursing profession by a woman named Mary McMillan, that you probably have heard of if you're in physical therapy, that pulled together a group of really nurses, and they called themselves reconstruction aides. So it was, and I think back of it, I thought about it yesterday, I go, this was kind of like a sexist beginning to our profession. You had women just treating men, and that was it. It was people at war, and it was the nurses doing it. And it was kind of interesting to think that's how 100 years ago, and that's what it was. And I think we've really kind of come a long way. So the first century of PT, we just, really met the needs of society. Society kind of demanded what we needed to do. And it was the physical therapists themselves that when they first started, that defined themselves and defined what the profession would be. And you'll see here in a minute, I kind of came out of a couple events or different events that occurred in the world and in the United States that really pushed the profession to where it is now. And in the very early days, it was these group of reconstruction aides that helped define themselves as a segment of medicine. And they're actually, physicians that call themselves physical therapists back then too. So if you look back at the early 1900s, you had World War I, and there was the war disabilities started. And then you had polio, which we'll talk about. So you had a disease process and an epidemic that prompted a reaction and a response that caused people to elevate their skill set to meet those demands and refine who we were. And then you had issues that were happening to the aging population in terms of stroke, and who was really going to take care of those people. Instead of taking people that had strokes and put them in a wheelchair and stick them in a home, it was, wait a minute, these people have potential, and there's interventions that can help them be more functional. So what are those? And then we get into non-surgical orthopedics and the aging population, which we'll talk about in a minute. But as we evolved as a profession, we also evolved in our practice settings that we functioned in. In the early days, there really wasn't anything. It was really the military hospitals is really where PT started, because they were handling the war injuries. And that's where the profession kind of got going. There really wasn't even the prevalence of private hospitals back in the early days. It was all government-related hospitals. And you'll see here in a minute that it was really funding to help create private hospitals that gave another setting for physical therapists. And then as a primary care became more of a mainstay for Medicare patients, there became a need for the primary care to kind of offshore or unload some of the care that they're doing as primary care physicians to other professions to handle. And physical therapists was a natural handoff for musculoskeletal and neurological conditions. And then we kind of evolved into the current times with our education, with the doctoral level, and the fact that we're getting into prevention and to wellness. In California, you may or may not know, but wellness is actually part of our Practice Act. That the term wellness is used. It's not defined, but it's used. So if we go back to the wars, and back in the early 1900s, World War I and World War II, set kind of the pathway for development and evolution of different techniques, different from everything from wound management to splinting techniques to movement therapies. And back when I was in the early days, we had neurological types of interventions, Brunstrom, bow bath. You may have heard some of these terms. that were Margaret Rood. There were all these pioneers, and a lot of them were in Southern California that initiated some of the different techniques that were used. And then, you know, I mentioned already, we were in hospitals, but they started developing rehab hospital wings of the hospitals so that they can handle this. And that's kind of where the long-term rehab began, again, back in the military side, but that really kind of set the model for it to move into private, the private side. And then the rehab medicine itself became a specialty where physical medicine and specialist, PM&R, physical medicine rehabilitation specialist and physician, that specialty was developed in the medical community, which really gave a lot more notoriety and a lot more focus on the fact that you needed the physical therapist to work alongside them. And then we had something that happened in the late 1940s and 1950s and even extended into the 1960s was polio. And polio was truly a societal epidemic that mostly struck young individuals, and there was it struck people of all ages, but really hit the young population, which elevated its kind of its presence and its urgency to be handled. And until the polio vaccine was developed, it was quite a crisis for people. And you know, who's going to deal with these people? Who's going to handle them? And these are long-term disabilities. So physical therapy really stepped up in that area, and it really established a great image for PT. That picture there in the bottom is something called an iron lung, and I don't know if any of you have ever seen those. When I was early in my career, we did a tour of Rancho Los Amigos Hospital. By the way, Rancho Los Amigos Hospital was where one of the fathers of our company, Vert Mooney, started as a medical director in Rancho Los Amigos, and developing non-surgical interventions for musculoskeletal injuries. So it's kind of interesting to tie that in. So I don't see Vert Mooney in this picture, but he could have been in it. And these are iron lungs. So these were the breathing machines before they had external respirators. They had the iron lung, which was a pressurized chamber that expanded in the lungs and pulled in oxygen to patients. And I remember in my PT, I've said in my early PT career, we toured the Rancho, the original facilities, and we all got into an iron lung. They didn't turn it on for us, but it's amazing the fact that people essentially lived in these things, and either they're rehabilitated or they passed away. And then the fact that we got into a little bit more of the bracing, the orthotic, prosthetic side of things too. And then as we got into the 1960s, we saw the treatment of strokes became a little bit more mainstream. And there was an act in the California Congress that allowed funding by the government, which is basically a loan or grants to private entities to create private hospitals that weren't government-related hospitals. And that really, then you started seeing community hospitals spring up. You started seeing physicians, groups of physicians open up their own hospitals. And I remember the days when we had community hospitals all over the place, and those hospitals may have been 50 beds to 100 beds. Those are mostly gone now, but it was groups of physicians that opened those up with government funding and their own money. And in those hospitals, they wanted to provide all services, so they put in PT departments. And that really increased the demand for PTs and caused PT schools to open up to meet those demands. And that really sparked the development of more rehab facilities and then subspecialty centers for different types of injuries. So 1940s, stroke, polio was really the foundation for creating an environment where our profession was able to latch on to grow. And then in 1965, they had probably the biggest event from the government that moved our profession into another whole practice environment. And so in 1965, the establishment of Medicare occurred. And what Medicare really did was provided funding for individuals with a permanent disability or those over 65, and then gave them access to outpatient care. So originally, the insurance that people had back then really covered more acute care conditions. So if you don't have people having any kind of funding for outpatient care, you're probably not going to seek out a physical therapist in the outpatient environment. And if you did that, you would go to a hospital because physical therapists didn't really open up private practices. So not until the 1960s did we really see physical therapists moving into private practices. And then you also saw orthopedic surgeons not just treating a surgical condition, but treating non-surgical conditions, which would spur the need for the orthopedic surgeons to have partners to see their non-surgical patients, and that were physical therapists. So, and if you go back and you look at even back to Vert Mooney's book that he wrote, which is a great book on kind of the evolution of physical therapy from a non-surgical standpoint, he talks about these things and how that evolved and how the demand was there to create environments for individuals to seek non-surgical care. So that really started the private practice. I remember my first clinical rotation in 1978 was in a private practice in the San Fernando Valley with a gentleman named Michael Weinper. And Michael Weinper was the father of a company called Physical PTPN, which is a network, a national network. And he was really unique. He was the first graduating class of Cal State Northridge. I was in the 14th graduating class of Cal State Northridge. And he was considered a pioneer in private practice just at that time. So our private practice profession and history is not that old when you think of how much it's matured and what we've become since then. So there's a lot of events that occurred along the way here. And the physical therapists really kind of filled that gap. And as we got into treating individuals, our techniques developed. We utilize influences around the world, going back to everything from to Syriacs to Maitland to Colton Bourne, to a lot of people, the manual therapists and the people that kind of centered on movement and manual therapy. And manual therapy got introduced into our profession as really as a basic need. And obviously there's a chiropractic profession, but physical therapists wanted to incorporate the manual side of things into their emphasis on exercise. So our services began to have a large demand, and they became part of mainstream coverage for insurance companies because there was a lot of referrals for them. There was a demand by the public that said, hey, I want to be able to access this. And private insurance companies adopted some of the guidance given by Medicare to say Medicare covers it, so private insurance should cover it. So as you get more coverage, more people access, more demand. So if you look at our current trends on where we're going, the fact that we moved to a doctoring profession in the 1990s was probably the biggest move for us, from elevating both the level of our education and what's contained in education programs and the accrediting standards to the public recognition of what the expertise is in physical therapy. So I go back, since I'm the oldest one here, I go back and look at when I came into the profession, that at the time I graduated, my bachelor's degree was not in physical therapy. It was in health science. And I got a certificate in physical therapy. And my certificate was from Northridge and UCLA back then. We went to school both places. And that was a certificate in physical therapy at a baccalaureate level. There wasn't even a master's in physical therapy. And then after I practiced a while, within 7 or 8 years, they moved to a master's level program. I went back for my master's, but not in physical therapy. And they moved us to a master's level as an entry level. And the one thing that's interesting and unique in physical therapy is that all of our education programs in the United States, and some in Canada, and actually some overseas, are accredited by one entity, which means they have all the same standards for education and accreditation. That's not necessarily true in other professions. It's not true in nursing, and it's not true in some other healthcare professions, where they have the ability to accredit with different entities in different parts of the country. And then that makes it kind of a little more difficult to be mobile with your license to go to different states. So if you take the National Physical Therapy exam, you have the ability to get licensed in other states if you pass their law exam. or there's reciprocity between the states, which California doesn't have yet. But the fact that we have a standardized education now at the doctoral level is pretty unique. And in fact, in the California state system, the CSU system, the schools that offer the doctorate, including San Diego State, the state system, the CSU system, was never the system in California that provided education at the doctoral level. That was the UC system. So back in 2015, when we went to kind of uniform doctoral level accreditation, maybe it was 2010, we had to get California CSU system to approve a doctoral program in physical therapy. And they go, we don't do doctorals. The only doctoral program the CSU system had was a doctor of education. That was the only one approved. But we were able to get the doctoral program to move into the CSU system for physical therapists. If that didn't occur, you wouldn't have programs at the state schools because they wouldn't have been able to meet the accreditation standards. So the profession of physical therapy has kind of elevated a lot of things nationally in the state of California. And so the DPT has now become the norm, but there obviously you can always practice without a DPT because the state of California and other states recognizes that if you're licensed at the time that the accreditation standards were at a different level, that you're recognized there. So we then moved into the idea that now we are the experts in movement analysis, and that's really where we want to go. And being the experts in movement analysis has really kind of shifted that pyramid that I showed you in the beginning, where physical agents where we were at. Now you tend to take a look at it. Those physical agents are probably at the bottom of the pyramid. They're an adjunct to what we do. They're not the primary intervention of what we do. That we are movement specialists. We are the individuals that get people back to function. And in order to do that, we employ everything else in that pyramid. But that's the top of the pyramid now. And it is the main thing that we do, where the other entities support are basically the means to the end. And you'll see that this basically everything that we do is we modernize our practice active things are pushing us in that direction. So our identity has really changed over the years, going from aides, reconstruction aides, supporting physicians in the field and military, to being doctors of physical therapists in a wide variety of settings. Has really, if you think about 100 years, I mean, that's pretty remarkable to bring a profession that far. So it gives me a lot of hope in all of us that we are going to move this even further. And there's a heck of a lot more potential as we gain more recognition. And as the education has gone from even from the point where it wasn't even a baccalaureate level, and it was the American Medical Association that accredited PT schools. And back in 1945, USC, there's argument whether it was USC or Children's Hospital, which is now Chapman, or a school back east that were the first formal physical therapy programs in the country. But there's always that fight of who really had the first one. But back then, there wasn't a national accrediting entity, so you can argue as to who actually had the first school. But it was, so back to 96 was the DPT. And the fact that now we are, moving into a level of autonomy where we have direct access. In fact, there's discussion in the last 2 days about how quickly we can remove the limitation on our direct access requirement that says, we can treat an individual for 12 visits or 45 days before they have to have a signed plan of care or a diagnosis from a physician, to remove that requirement in California, because what has occurred is nothing has occurred, meaning that people have not been harmed by direct access. There's really no complaints on file in the state. So why should we have that restriction? So our level of autonomy continues to evolve through this process, and it will continue to go beyond that. And you see us involved in primary care, working in emergency rooms, not in general medicine, but in the areas that we have expertise in. So our vision statement from the APTA, and I know Spine and Sport is developing a vision statement as we speak. Some of you are involved in that process right now, and many of you gave your input early on. But the vision statement of the APTA is transforming society by optimizing movement to improve the human experience. I have to tell you that a lot of this terminology came from Californians, and this was done in the House of Delegates a number of years ago. but it kind of evolved out of California. So we talk about the fact that we're here to optimize movement, and we improve society, transform society, and improve the human experience by doing so. So the question is really, what do we want to be? What do we want going forward? This is kind of like, we have a few minutes left to open it up to people who want to ask questions or have any sense of, what things would you like to see us be able to do? What things have you been wanting to learn or do, or you think the direction we should go? Because right now we are in the process, we as a profession in California, and as the president of California PT Association, we've developed a work group, a pretty intense work group, that we are in the process of trying to modernize our Practice Act in California. It's going to be a multi-year process, but we're going through everything to say, this is how we want to function going forward, as opposed to being restricted by our Practice Act. So I'll open it up now. Do you guys have any input or questions or anything regarding, what you like to see us be, or see physical therapy be, or to do, or questions you might have in anything I said? I'll open it up.
What about us, the older physical therapists? If we'd like to get a doctorate in physical therapy, it's a lot of money now, it's a lot of time consuming. Any idea, are we going to be backfathered or whatever, dead fathered, whatever you call it?
Well, so yeah, that's a really good question. There is discussion of moving everybody to being able to use the term doctor of physical therapy based upon the fact that you're a physical therapist. However, that will be a state by state move, because every state has their own licensing, and that state has to approve the ability to do that. So right now, you only can technically call yourself a doctorate if you have an educational doctorate to back that up. And as you probably know, there still are transitional doctoral programs out there, but as most people who have wanted to transition to a doctoral level have done so, those programs will slowly go away. So, I say if you want to get to the doctoral level, you probably should look into it soon. And the cost, I can't really comment on that because everything is a business, and so there's not going to be a way to reduce that cost. But those programs will probably phase out over the next 5 years or so. They'll probably be gone. But maybe within 5 to 10 years, you might be able to call yourself a doctor of physical therapy in a clinical setting without being the educational doctorate. But I can't say that's a discussion, but it's a long process, and it'll happen state by state. Any other questions?
Which one is your favorite transitional
program?
Mm-hmm.
I don't have to. I went through the EIM program, which I thought was great because they have both a clinical track and an administrative track for it. But it still includes the clinical side, even on the administrative side. I looked into a number of them when I went. Chapman used to have one. I think they're phasing that out. St. Augustine had one. AT Still was a great one. That was the one I was going to go to out of Arizona. You can look up, I think, on the APTA website. It gives you a list of those programs.
Thank you.
Any other comments or questions? Anything on this list that you'd like to see happen, or it would be a priority for you to be able to do in practice?
I think ordering imaging would be awesome if we could get that in our Practice Act.
Yeah. So right now, the opinion of our PT licensing board is you can order imaging, saying that there's not a restriction on doing it, but it doesn't specifically authorize. It says that we can't perform imaging. It doesn't restrict us from ordering imaging, but it's so kind of generic right now that the restriction really is that radiologists don't honor us ordered imaging. So they don't honor it, and insurance companies won't pay for it if we order it. So putting it in the Practice Act specifically will move the needle on those two things. Would say, okay, we can order it, and we now tell the insurance companies that we would expect them to pay for it because the radiologists will accept our orders. So we have the ability to do it now, but nobody will let us do it. But
Can't do anything with it.
that's one that we're working on. Okay, I know we're at 1 o'clock, so you guys have to kind of check off. Is that true, Dina? We have to kind of wrap up. So just so you know, to kind of think about this list and email me, any ideas you think if one of these areas you really want to see something change or happen on, and I will comment you back on what's happening in that area, because there's a lot of discussion in each of these, plus a heck of a lot more too. So thank you all. Happy 100-year anniversary and happy PT month.
Thanks, Rick.
Thank you so much, Rick. This was amazing.
Thank you, Rick.
It has been recorded too, so if anyone wants to use this for a staff meeting and show everyone, I know I do that with my team. It is a great educational tool. So thank you guys so much and happy PT month.
Thank you. Bye.
Thank you. That was great.